Bismillah, and today we are in Somalia again, Mogadishu, and we are doing for 8 years of my patient having bladder stone and huge prostate. We already finished the bladder stone. The stones? Yeah. We already finished the stones, and this is the one of the remaining stones here. So now we're going to start the bipolar enucleation. For the prostate, we use the resectoscope. So we use the mechanical enucleation rather than the labor enucleation. As you see, this is the Vero. I make two trough, 6 o'clock trough, 6 o'clock trough to get water come back. And I make also 12 o'clock trough, as you see. So these two troughs will help us, number one, for marking lines. They will guide us that if we go different area, we will come back to 12 o'clock or 6 o'clock, so we can see our guidelines. Second things, they help us that they will cancel the association between two lobes, so there is no any connection between two lobes. This will make easier for enucleation. Okay. So when we start the enucleation, first we make the marking lines to prevent the sphincteric damage. As you see, with the valve, we start from here, with the mechanical. And this is the capsule. This shiny space with the vessels is the capsule. So close the vessels. See, this is the valve. This is the enucleated left lobe. So we'll go on this line, capsule. See my hand? I just rotate him and not pushing using force. If you use force, it's easier to perforate. And every time you must come back to see the vessels that you already enucleated, you rupture it, so it will bleed, you see? The vessels, they bleed. So it's better to coagulate and then continue for enucleation. Okay? Okay, we continue down, upside. Don't go in, go up, go towards 12 o'clock. See? Rotate, 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 rotate. And then come back for coagulation. Don't become over enthusiastic that you get so quickly, so that time the patient may bleed and you lose your vision and make your job difficult. This is one of the prostatic chips. Okay? Don't miss the capsular line. Go without force. Come back and then go with the prostatic contours. Go rotate, 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 rotate. See my hand now? See? Just rotate it up to 12 o'clock. Okay? And then go back for coagulations. As you see here, the prostate is a little bit rough. And now, before you enter the bladder, come in here and make another trough here. And this is the 12 o'clock, huh? Make a small trough here. So this will facilitate that enucleation process will go easier. Trough. So this is my entrance done to the bladder. Okay? Now we go back to the Vero from where we start. And the Vero, okay? Go in, rotate 3 o'clock, rotate, 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 rotate. Then enter, come back another wave by wave, okay? Rotate, rotate, Go up. This is the capsule. Okay, come back. Deviate again. The video is clear, Arfan?
Yes, yes.
I feel that the water is less. Prostration is the vascular layer is the prostatic capsule, surgical capsule. Okay. You see? Now I enter the bladder. You see? When you enter the bladder, it means you've done 80% of the job. Now our mission to come back and close the vascular, ruptured vessels. Otherwise, the patient will bleed. The advantage of the bipolar enucleation is coagulation is better than the laser. The laser you can't coagulate well, and you are not using the mechanical. You are not using anatomical enucleation. You just cut. It's easier that you go to false passage. Okay, and then. Come back to 12 o'clock. Come back to your trough. The trough you made, you remember? I don't want anyone to talk, huh? Please. Come back to your trough. You see? This is the bladder. So you can cut. Wait. Stop the video, Arthur. So as you see, guys, I put more time on coagulation because you don't need any bleeding. So if there is a bleeding, you lose the quality of your vision. Surgical capsule. I was just editing the. Here is the fossa, and this is the right one. This is vessels is the right layer. This without vessels is the you go to false passage. So when you go to false passage, you come back where you have a good capsule and you continue for enucleation. Otherwise, you will go to become your enucleation difficult. It's like a peeling an orange. So you can layer by layer. When you go to wrong way, you come back to get the right shape. Okay? Almost no bleeding. Now I search what they say in China, Yue. So this is the Yue. Yue in Chinese means the fish tail. Fish tail. This is where the 12 o'clock, the membranous layer. So if we cut this, we can force a little bit, it becomes easier for cutting. Blade and cut. So push and cut, don't only cut. So another advantage of bipolar enucleation is you have the feelings with you. there is association between two lobes, so that's what I will be classified. Now the two lobes have no any contact. Set this line of that. Okay. That's how we do it. You see? This lobe is free, that lobe is free. So now the cutting will be easy. So if I have the oscillator, now I can push this lobe to the bladder, push the other one to the bladder, and make the oscillation. So the surgical time will be half hour. But now we need to suffer to cut these prostatic chips by using bipolar. It's like TUERP. Down. As I feel there is some association here at the bladder neck. Before you cut, it's better to go all the way up, up, up. And now you can. Now you can appreciate that there is not any bleeding from our cutting. You see? Bleedingless. This is the beauty of enucleation. If I do normal TUERP, every time I cut, I should coagulate, it will bleed. But now, no bleeding at all. Fossa is not very big, it's 6 grams. So I hope we can coagulate this time. You put butter and follow me. Always, when you want to cut, go back to the enucleation line. Go back. Here there is some association. More, so maybe his prostate will slips to the bladder. So that time I don't have oscillator, so I should cut over. Travel up a little bit, please. Okay. So I can cut both directions. Here there is bleeding no oil, it goes from the other lobe, unenucleated lobe. But our enucleated lobe have no bleeding at all. You see? I'm cutting both sides. When you cut both sides, it's not safe. You need time to adapt. Biar maklum. Not sosok kiri ya. So when you are cutting, don't cut in one part. Just cut all the way from the prostate. So if you cut one part of the prostate, maybe that part become less than the other part. So the mizan or the tawazun, the balance of the prostate will lose, and the prostate will move. so it becomes difficult for you to cut. So cut from left to right, and then from right to left. Okay? Start from bladder neck to apex. Okay, after that, just stop so we don't want to lose a lot of time for our video. Our friends, this is called prostatic balls. You see, the prostatic chip. This is going through enucleation line. So now we need to cut it with prostatic balls. In China we say 水性角. This is circular tissue. So we are cutting the prostatic now all the way. This is the remaining on this loop. Okay, keep cutting. Okay, easy, stop. So prostatic apex is the fossa. We already enucleated one loop. You see? Enucleated and then cut it, dissect it. Okay? So now we're gonna start the other lobe from enucleation. So this is now prostate. Here's the prostate. So this is the enucleated left lobe. We're gonna start the right lobe. The beauty of the bipolar resection and enucleation, TUR, transurethral resection and enucleation process, TURED. This is the Chinese technique. They come from the Nanfang Kadashi and Guangzhou Southern Medical University. So that professor invented this procedure using a TURP resectoscope, enucleation and dissection of the process. So we almost finished one lobe. We're going to start the other lobe from the Vero area. See, we're going to insert here and then enucleate.